I'm really happy to see so many faces today, and the kind of engaged conversations that we got in before the break really stimulated a lot of my thinking, and I'm really happy we're here. I was also thinking about Gary's opening and talking about the replication of corporate forms of regulation, and how that there's a long story to the formalization and depoliticization of aid service organizations that I think that the work that I'm going to present to you today, that was my thesis research, fits into. And I think it's good to think about sort of advancing some of the questions you're putting forward, sort of decisions that get made within routine day-to-day norms of institutions that trickle down into community organizing work or community-based organizations work that don't have an opportunity to be opened up, to be talked about in different forums. And when you look at that, you see where power is centralized in some ways, but then you also see that there's an avoidance sometimes of dealing with some of these issues. So I'm hoping that we can get to some discussion about some of this stuff today. I think Gary also mentioned like within, against, and beyond, and my study that I did about evaluation at aid service organization is very much a study of like within, of what it looks like from the inside of these institutions at this moment, the two that I studied. So I worked at community-based organizations. I've worked as a professional evaluator, and I started my PhD, and I thought that some of the stuff that I had been doing just as a normal course of practice in my work could warrant further attention and study. So I did this thesis project called Frontline Measures, which was all about evaluation at HIV prevention, evaluation of HIV prevention programs at aid service organizations. So this is in the context of 30 years into the epidemic. There's renewed urgency for HIV prevention. You know, rates in some populations are stable. It's still unstable in other populations. And there's ongoing uncertainties about the impact or the effectiveness of the HIV prevention work that we do carry out. And this is in the same sort of context that the HIV response has been working in for many years, where there's tensions about who are the real experts, who really knows what works. Is it people living with HIV? Is it the organizations that are trying to serve effective communities? Is it researchers or policymakers? And there's tensions about the kinds of positions of power that those different groups occupy. In addition to this, with neoliberalism creeping in all kinds of ways, there is increasing amounts of accountability and monitoring and reporting requirements for all public institutions. The scrutiny that public dollars and how they're being spent has mounted, although this seems to be at a time where the general public also doesn't seem to be, even when they receive more detailed monitoring information about what's going on, the trust that government institutions are working on their behalf or representing them also doesn't seem to be increasing. And yet, the monitoring of where public dollars are going seems to be like the way things are done now. It seems accepted. There's also this movement in lots of health and social service professions towards evidence-based practice. There's some people who have written about the emergence of evidence-based medicine in the 1990s and the various forms of acceptance, proliferation, as well as resistance to evidence-based practice. And so some of the responses have been to sort of make best of the bad situation. I think actually John mentioned this in one of his comments. So if we don't do it ourselves, it will be imposed on us, right? So at one point, a collection of doctors were starting to feel that evidence-based practice might actually, even though it was unpopular at the time, might take off in their profession. So instead of having people who weren't doctors telling them what evidence was and what good practice was, a group of doctors within that field decided to say, let us make the rules for ourselves as a form of resistance from external control, creating internal levels of control within the practice. Who was deemed someone who had access to evidence, who was able to make it, was able to interpret it, who was able to dispense it to other practitioners, and who was able to sort of regulate or judge whether it was happening well or not. And I think that's very important to think about, because a lot of the social service work and the AIDS organization that is happening within community-based organization is very much affected and in some ways controlled by these trends in the larger social service and health contexts. There's also, in addition to this sort of creep of monitoring, there's also more pressure to evaluate and to prove outcomes in particular. And it brings up issues within the evaluation world of like, what is the reason behind any particular evaluation? Is the purpose behind it for oversight and compliance, or is it for learning and program improvement? So both of these are embraced as like very important reasons, and sometimes they're conflated. So it's within this sort of package of the context that we're in right now that I wanted to look at what evaluation practice was like in depth at some community-based agencies. And one of the reasons that was prompting this was that a framework came out of the US, the Centers of Disease Control, really took a leadership position to try and address this impact and effectiveness issue. And they put together a whole way to construct programming, which they've called the DEBIs, which is the Diffusion of Effective Behavioral Interventions. So this is evidence-based practice in HIV work. And so what they did is they decided what an effective program was a program that had been run either devised entirely by researchers or devised with community organizations working with researchers, had a randomized controlled trial attached to it that showed positive, statistically significant effects in reducing self-reported behavior change of the people who received the intervention, and then had 2 articles written about it in academic journals. And those were considered evidence-based interventions that had been rigorously evaluated and were definitely going to have an impact, and only those programs were chosen to be part of this system. They were then packaged in a way that different community-based organizations could learn about them, and then there are certain jurisdictions that will only provide funding if you carry out one of these sort of approved programs, and everything else is considered, well, there's a tier of programs that haven't been shown to be proven yet, but they're based on a theory, and those are considered promising evaluations. And all the other work that community-based organizations or any other group has ever done to respond to HIV is simply considered an unevaluated intervention at the bottom of the pyramid, and it's not considered effective enough to be talked about or to distributed or to be practiced anymore. And I found this a little disturbing based on knowing about the work that community organizations do and the history of where all of this came from anyway, right? The idea that safer sex was not devised by public health workers, it was devised by communities that were responding to the impact with the best knowledge they had. So I did an in-depth investigation into evaluation practices that were happening at 2 agencies. I'm trying to keep the agencies confidential. I'm trying to intentionally keep the people I spoke to confidential because I wanted to get as much as I could to critical or alternative thoughts that might be happening. I spoke to 25 people, funders, volunteers, and I also spoke to managers of ASOs. So these are people really within the work right now. They're funding the work, they're carrying it out, they're learning from each other, like the volunteers are learning from staff and management how it gets carried out. And I also reviewed documents. I looked at about 100 documents that are used internally. I looked at a lot of OCHART reports in ways that people don't usually look at OCHART reports. OCHART is the funding system, is the reporting system that the federal and provincial government have harmonized their reporting requirements. And once a year they host a KTE meeting and they produce a report that's about 75 pages long with all the aggregate results from all of their funded programs. And what I found from all of this was that the ways in which these organizations are trying to keep up with the system that's around them is rather complex, and the amount of evaluation they're doing is multiple. So these agencies are carrying out, and they're trying to keep up with what's required of them, mainly from their government funders. Everything else is happening concurrently that they might be doing to assess how their work is going. But the government funding reporting is very much the most predominant evaluation practice happening at these agencies. So special evaluation reports are written that get produced when there's enough funding for it, or a particular person has enough time and skills in their job. And then there is government funding reports for municipal funding, provincial funding, non-HIV funding that might be required. And so there's a lot of government forms being filled out in order to report to all these different funders. At the same time, I would say the richest amount of information that these organizations are generating about their programs, about the work they do, is tacitly. So explicit knowledge is knowledge that can be written down and can be captured in a form. Tacit knowledge is embodied, experienced knowledge that can be very difficult to articulate. So if you're at a work, or if you have a volunteer position, and you just try and write down everything you do in a day so someone else could do it, you would be missing a large amount of what you do and what you know about what you do and how you make decisions. That's your tacit knowledge. And the people who work in this field are often bringing their tacit knowledge, combining their professional lived experience with their personal lived experience, either having HIV or being from a community that's very affected by it. And it's this tacit knowledge that is where the most relevant responses, where the most relevant decision making about programming comes from. But this tacit knowledge isn't usually valued or well understood, and it's certainly not captured in most government reporting forms. The kind of work that's carried out by aid service organizations doesn't lend itself well to neat checkboxes about how to evaluate it on paper. Although there's been a lot of attempt over the last number of years to try and capture that. So when I spoke to people about what they were actually reporting about, you know, one of the things that they could, that was very important to people who were carried out in funding the programs was popularity, was the amount of people taking part in a program, or the amount of people who were retained by a program. But even that, the popularity of the program was usually tacitly measured. So it's fine to have, you know, like 6 guys who come to a workshop. But do they actually stay and have a conversation afterwards? Do they ask questions? Do they end up speaking with each other? That ended up being one of, for the workers who are actually carrying out the work, the tacit way of judging whether this was working or not had a lot more to do with what they knew from their context and from their peers than the kinds of forms that you might like learn about, you know, like if you were trying to follow a textbook in order to carry out a workshop. But at the end of the day, overall, an agency has a lot of different stakeholders to report to. They have the government funders that they're trying to maintain their relationship with. They have the staff and the people who work there and the volunteers. And then if they have a membership, they have members that they're trying to speak to. They may also receive money from foundations. All of these different audiences want to know different things about the work that's getting done. And I would say that the development of methods to remain accountable to all these different audiences is not happening at the same pace. So in order to maintain relationships with funders, accountability mechanisms have developed so people know how to fill out O-charts and are present for all of that. However, the ways in which an organization might be accountable to its members or to the community that it's seeking to represent is far less well developed. It's much more ad hoc. And so there's concerns about that. The other thing I'd say after speaking to a lot of people in these agencies is that, you know, ideas about doing HIV prevention work, what is the ultimate goal of it? How do we know it's working or not? And when we look at evidence-based practice, when we look at the CDC model, either changing behavior, changing self-reported behavior is the key indicator that these sort of systems suggest is that's when we know HIV is working well. But really the biggest undercurrent that I heard when I was speaking to people about their work was that the relationships that were built by doing this work were the key thing that was helping either the community or individuals who are at risk. So these are individual relationships between participants, but these are also people in relation to their community and these organizations in relation to each other. And relationships are very poorly captured in quantitative evaluation measure. They're also not so well articulated, and there's this gray, murky zone, because relationships can be sources of frustration or abuse, as well as being something positive and health promoting. So I think if we're going to continue on this way of trying to manage within this system, that we could do a lot more in articulating what it is about a healthy relationship, or how do we know when a relationship between organizations, between people, are actually working. And that might actually get us somewhere further. I just want to, like a little bit over time, but I just want to say one last thing. Evaluation practice is incredibly linear, and it doesn't capture the complexity of work that goes on very well. And so I think this, if we don't do it ourselves, it will be imposed on us. I think we really have to think very much of, like, if we do it ourselves and accept this very linear way of thinking about programs and how we make decisions about them, how are we going to do justice to the complexity of the work that we know? The tools that we are being asked to pick up are meant to constrain us. And there is an importance of remaining accountable to funders who are trying to report back to a general public that may or may not be concerned about HIV. But if we neglect the mechanisms in which we remain accountable to ourselves, to our communities, to the members of our organizations, we really lose a lot. So I just wanted to say thanks for listening to me.